At DNA Wellness and Longevity Institute, our goal is very simple. We want you to understand your options. Because when it comes to hormone therapy, confusion creates fear, and fear creates hesitation. Hormones should not feel mysterious. They should not feel scary. They should feel clear, informed, and personalized to you. Today, I'm going to walk you through the difference between bioidentical and synthetic hormones. We'll unpack the fear that came from older research, and we'll talk honestly about what the science actually shows. Let's start with bioidentical hormones. Bioidentical hormones are structurally identical to the hormones your body naturally produces. That means when they bind to your hormone receptors, your body recognizes them. They fit the receptor the same way your own hormones do. As a result, they often elicit a more natural response, and they tend to be better tolerated. This is why many patients feel more balanced when using them. Common examples of bioidentical hormones include estradiol. This can be delivered as a patch, gel, cream, or oral form. Micronized progesterone is another example. Testosterone can also be bioidentical, and in some cases, adrenal support hormones like pregnenolone or DHEA are used. Many patients notice improvements in sleep, in mood, in metabolism, and in mental clarity. That is often because the structure matches what the body expects. Now let's talk about synthetic hormones. Synthetic hormones are not identical to human hormones. Their chemical structure is different, and when structure changes, behavior changes. Examples include conjugated equine estrogens, medroxyprogesterone acetate, and ethinylestradiol, which is commonly found in birth control pills. These were widely used decades ago, and they are the hormones studied in the research that created widespread fear. That research was the Women's Health Initiative study. It is often mistakenly called the WHO study, but it was the Women's Health Initiative, or WHI. Many people still remember it as the study that said hormones cause cancer. But the full story is more nuanced. The average age of women in that study was 63. Many were 10 to 20 years past menopause. Most already had cardiovascular risk factors. Hormone therapy is safest when started within 10 years of menopause, not decades later. Now, let's go a little deeper into why the WHI study caused so much confusion. First, it studied the wrong population. The average age was 63. Many women were 10 to 20 years into menopause. Most already had cardiovascular risk factors. Hormone therapy is safest when started within 10 years of menopause, not in the late 60s or 70s. Timing matters. Second, the study used the wrong hormones. Only synthetic hormones were tested. There was no estradiol, no micronized progesterone, no transdermal patch or gel. The study used high-dose oral synthetic estrogen combined with synthetic progestin. That is very different from modern bioidentical hormone therapy. So applying those results to today's treatments is not scientifically accurate. Third, the way the risks were presented was misleading. The absolute increase in breast cancer was very small. Less than one extra case per 1,000 women per year. That is important context. And in the estrogen only arm of the study, breast cancer incidence and mortality were actually reduced. That crucial detail was not widely publicized. Because of these limitations, the WHI results cannot be directly applied to modern bioidentical hormone therapy. Now, let's talk specifically about breast cancer risk. When synthetic estrogen was combined with synthetic progestin in the WHI study, there was a small increase in breast cancer risk. That risk was driven primarily by the synthetic progestin, medroxyprogesterone acetate. When we look at bioidentical estradiol combined with micronized progesterone, studies show significantly lower breast cancer risk compared to synthetic progestins. For the first 3 to 5 years of appropriate use, there's no significant increase in breast cancer risk. In women who do not have a uterus and use estrogen-only therapy, data consistently show lower breast cancer risk and decreased mortality. This is very different from the public perception many people still carry. Again, the type of hormone matters, the timing matters, and the formulation matters. Those details change outcomes. Now let's shift into endometrial cancer risk. For women who still have a uterus, estrogen must be balanced with adequate progesterone. Bioidentical progesterone safely protects the uterine lining when dosed appropriately. Unopposed estrogen, whether bioidentical or synthetic, increases endometrial cancer risk. That is why proper progesterone therapy is essential. This is standard and responsible medical practice. When we move into cardiovascular risk, stroke risk, and blood clot risk, several factors increase risk. Starting hormone therapy much later in life increases risk. High-dose oral synthetic estrogen increases risk. Synthetic progestins increase risk. And pre-existing vascular disease increases risk. These factors matter more than hormones alone. What reduces cardiovascular risk? Starting hormone therapy within 10 years of menopause reduces risk. Using bioidentical transdermal estradiol reduces clot risk compared to oral estrogen. Using micronized progesterone instead of synthetic progestins improves the cardiovascular profile. And lifestyle optimization matters. Exercise, nutrition, stress reduction, all of this works together. Transdermal estradiol does not increase clotting risk the same way oral estrogen does, because it bypasses the liver, and it does not elevate clotting factors in the same way. When we compare other side effects, bioidentical hormones are generally better tolerated. Progesterone improves sleep because of its natural calming effect in the brain. There is a lower risk of mood disturbances and a lower risk of gallbladder issues when using transdermal estrogen. Synthetic hormones are more commonly associated with mood changes, irritability, anxiety, breast tenderness, higher clot and stroke risk when used orally, and they may interfere with lipid profiles and cardiovascular health. This difference in side effect profile is one of the reasons many patients feel better on bioidentical therapy. At DNA Wellness and Longevity Institute, our practice focuses on whole body longevity, safety, and evidence-based optimization. We choose bioidentical hormone therapy because it aligns with human physiology. It offers better safety data for many patients. It often improves sleep, metabolism, cognition, and mood. Transdermal options reduce clot and cardiovascular risk. And dosing is individualized based on your lab work and symptoms. We monitor your hormones, your thyroid function, your inflammation markers, and your overall wellness regularly. Our approach is comprehensive, personalized, and grounded in integrative medicine principles. Hormone therapy is not one size fits all. It must be tailored. Bioidentical hormone therapy is a safe and effective option when used appropriately, especially when started near menopause and monitored correctly. The older studies that caused concern involved synthetic high-dose hormones in older postmenopausal women, not the bioidentical therapies used today. If you have questions or would like to review your personalized plan, our team is here to guide you safely and thoughtfully. You do not have to navigate this